today's topic. In competency 1, there is another part. I deliberately omitted that part. Otherwise, it will be very difficult to understand. Two complicated things are attached together. So I am separating it into two classes. Let's see what happens. The heart. What is this? This is an hollow organ, conical in shape, muscular. Okay? And it is having one circulatory system, vascular system. Through these vessels, something is circulated. What? Blood is circulated throughout the body. Okay? So it is accompanied by a circulatory system. And this circulatory system pumps blood through these vessels to the different parts of the body. How the heart is doing this thing? By pumping. How it pumps? By repeated rhythmic contractions. Repeated rhythmic contraction, not haphazardly. So this way the heart works. Cardiovascular system, cardiac muscle. So we use the term cardiac. This term actually comes from Greek word. It means, cardiac means related to heart. And actual meaning of heart is cardia, K-A-R-D-I-A, cardia. So this is the Greek word. And what is the size of the? You make a fist with your hand, like this. And this is the size of your heart. Now you can guess what would be the size of your heart. Okay, it is also cone shape. Here is the cone, this is the apex of the ventricle, and this is the base of the heart. Okay, and its size, if you measure, it will be, the weight will vary from 250 gram to 300 gram. And its dimensions, length is how much? 12 centimeter long, and breadth is 9 centimeter, and width is 6 centimeter. Okay? Fine. Understood? After this? Fine. Now the location of the heart. It lies within the thorax, above the diaphragm, within the thorax, in between the right and left lung. In between right and left lung, there is a space. This space is called mediastinum. So, heart is located in mediastinum. Very good. And you see, now, let us see. What is there at the front of the heart, anterior to the heart? What is there posterior to the heart? What is there laterally? And what is there inferiorly? Okay? If it is my heart within the thoracic case, in the mediastinum, so at the back of my heart, what you will get? Vertebral column. Anything else? Esophagus. Anything else? Trachea. Anything else? Descending aorta. You will find it at the back of the heart. Can we repeat? What is there at the back of the heart? So at the back, Spinal cord, vertebral column. Within this vertebral there is spinal cord. So this is vertebral column, then esophagus, then what is there at the front? Wait. Sir is asking you what is there at the front of the heart? Sternum, yes, very good. Very good. You tell. Next to you. Sternum is there. And these ribs are there. Ribs. And in between the ribs, what are there? Intercostal muscles. There are two types of intercostal muscles. Know that? Yes. External intercostal muscles and internal intercostal muscles. These are necessary for inspiration and expiration. So these are called respiratory muscles. Straight. And at the bottom, diaphragm. The diaphragm, the muscles of diaphragm are united in a central point, tendinous point. The ventricle, the tip of the ventricle, the apex of the ventricle rest on the diaphragm, particularly on the central tendinous part. Okay? And if you observe superiorly, this is the heart. I am observing the heart superiorly. From the superior view I am taking. So what you will see there? The vessels that come out of the heart. What are these vessels? The great vessels, what are these? Number one is aorta. Then superior vena cava. You won't see the inferior vena cava because it is you are observing it from the superior point of view. And pulmonary artery and pulmonary base. Very good. Now we could realize that what would be its location. First in a space. What is this space? Mediastinum. Okay. Now what is there? And the heart. The heart. Is it in the mid position? Slightly towards left. It doesn't mean the heart is not having any part to the right. The most part is towards the slightly towards the left. Okay. So these are the positions of the heart. We have already told this. So these are actually those parts. In relation to your thorax, see the position, see the heart, position of the heart in the thorax. Now, we will study the heart. It is enclosed within a sac-like structure. Within a sac-like structures. And these sac-like structures are called pericardium. And this pericardium is having three layers. The outer layer, outer pericardium, is called fibrous pericardium. It is very tough, non-elastic. Tough and non-elastic. Why it is such? Because it is protective, very much protective for the heart, so that in any case, heart doesn't expand too much. and it is protected from outside. It protects the heart from outside. That's why it is fibrous tissue, made up of fibrous connective tissue. These are toughened heart. Okay? So this pericardium is made up of 3 layers. Outer, fibrous, and inner, serous layer. 2 serous layers. And you can call it as sandwich. These 2 layers, this is the outer fibrous layer, and the inner serous layer forms a sandwich. In between these 2 layers, these are serous layer, in between these 2 serous layers, there is a cavity. It is called pericardial cavity. And it contains a fluid. Its function is the lubricating fluid. This fluid acts as lubricant. The amount of this fluid is how much? 5 to 30 ml. If any condition, in any condition, for example, endocarditis infection of this serous layer, there may be accumulation of excess fluid. This is called pericardial effusion. Pericardial effusion. This sort of effusion can also be seen in interpleural space outside the lung. Anatomy of the lung you have studied? Anatomy of the lung. What has been taught in the first class? Respiratory system. The lung. It has no direct contact with the rib cage. Here also you will find 2 layers, serous layer. One layer covering the lung and another layer covering the serous layer covering the thoracic cage, inner surface of the thoracic cage. This is called parietal pleura. Pleura covering the inner surface of the chest cage is parietal pleura. And the pleura covering the lung is the visceral pleura. So in between there is a space. It is in case of lung. This space is called interpleural space. Here also you will find not fluid, a gas. And it remains always in, the pressure is negative in respect of the atmospheric pressure. As a result, in this space, the pressure is always negative. As you do one thing, take a balloon, put it here and suck it. What will happen? The balloon will be inflated within the mouth. Why? Because you have created negative pressure within your mouth cavity. And the atmospheric pressure is high. So it is pushing the balloon towards your mouth. Similarly, if the negative pressure is there in the pleural phase, the lung, it is elastic in nature, it will remain expanded. Even you are not breathing in resting condition, to some extent, lung will remain expanded. In case of accidents, what will happen? The atmospheric air may enter within this space. No negative pressure. The pressure will be same as atmospheric pressure, As a result, what will happen? The lung, because its elasticity, it will collapse. To prevent this collapsing, always a negative pressure is maintained within the interpleural space. Anyway, that is not the subject of today's lecture. So within this interpleural, within this pericardial cavity, we get a fluid, and it is what type of fluid? Viscous fluid, lubricant. It acts as lubricant. What is the function there? So when heart will be expanding, relaxing, the wall of the heart may undergo friction with the layers of the pericardium. So there may be tearing. So prevent that, this lubricant protects this friction, helps in easy relaxation, easy contraction of the heart. So these are the purpose, function of the interpleural space. Now, see, this black area, it is the cavity, What is this name? What is the name of this cavity? And outside this, pericardial cavity contains serous fluid. And outside this is the fibrous pericardium. And these are the two serous layers. These two serous layers made this sandwich. What is there inside? Within the serous fluid. Now we will give name to this layer and to this layer, to this serous layer. One layer, the outer layer, it covers the inner surface of the fibrous pericardium. And it is the parietal serous layer. It is the parietal. Sir, hey, I will be asking. Tuli dar korabo, and then I will ask. Be prepared. And this layer, serous layer, it is visceral layer of pericardium. This visceral layer of pericardium is also termed as epicardium. Remember this, epicardium. So you learn a word, epicardium. So what is actually epicardium? It is a serous layer, and it is the visceral serous layer, a part of pericardium. With both the serous layer plus the outer fibrous layer together is the pericardium. So pericardium is made up of 3 layers plus the pericardial fluid, and this epicardium is also a part of wall of the heart. Is also a wall of the heart. Now see, this pericardium, fibrous pericardium, here it is fused with the fibrous pericardium from all sides are fusing with the great vessels. They are fused there. And the other end of this fibrous pericardium, other end, this is the other end, it attaching with the diaphragm. So, this sac is attached at the top with the vessels, blood vessels. Here they are fused, and the other end is fused to it, the diaphragm, and it is having at the center, it is a tendinous part, and here it is joining the tendon, so that this part remain fixed. Now within this, the heart will be pumping, relaxing within this safely. Okay? Now, I will take a part of this to see what is there in the wall of the heart. Are there single layer or there is some other layers are there? We will study. So this is all about the pericardium, epicardium, we came to know. Pericardial cavity, this is the, what is pericardial effusion? When the amount of fluid in the pericardial cavity is increased due to some sort of infection. For example, pericarditis. So this may cause what? Pericardial effusion. In case of any hemorrhage or somebody punched your chest, as a result, what will happen? This may damage the serous layer and the bleeding may continue within the sac, pericardial cavity. As a result, there will be more and more amount of accumulation of fluid within the pericardial cavity, and it is called tamponade. So there is difference between tamponade and pericardial effusion. You understood? Is that right? Clear? Difference between tamponade and pericardial effusion. So I have taken a portion of the wall of the heart, particularly ventricles. I have taken a portion, cut a portion of the wall and studying. What is there? This is the fibrous layer. This is parietal serous coat, serous layer, and it is the cavity, peritoneal cavity, and it is sandwiched, made this cavity as sandwiched, and here it is another layer, serous layer, and it is visceral layer. And this visceral layer is covering the myocardium. Is covering the myocardium. Myocardium are cardiac muscle cells. Cardiac muscle cells are flat, elongated, and they are joined to each other by intercalated discs. In between the intercalated discs, what are there? There are junctional tissues, there are desmosomes. When heart contracts or relaxes, arrangement should be like that, the cells doesn't dissociate. So that's why they are tightly attached to each other by desmosomes. And these cardiac cells must be communicating to each other through a junction, gap junction. So this will allow cytoplasmic continuity between the adjacent cells. If one cell is stimulated, this cell is also stimulated. If it is contracted, this one will also be contracted. So the heart muscle will work as a syncytium. If one is stimulated, immediately all other cells will also be stimulated and contracted, make a force. With this force, the wall will be able to pump out the blood. The pumping action of heart is actually due to which layer? Which layer is responsible for pumping action? Myocardium. Myocardium. Only these myocardial cells are capable of contracting and relaxing. So they are creating the force to drag the blood. And now see, this is the cavity of the heart. This part is the cavity of the heart, and this is the outside of the heart. And see, the myocardium, inner aspect of the myocardium is again lined by another layer. Smooth epithelium and connective tissue. First, after the myocardial layer, there will be a thin layer of connective tissue. And over the connective tissue, next to the connective tissue, there will be epithelial layer of epithelial cells. Okay? So both them, this connective tissue and the epithelial cell together will make endocardium. Endocardium. And this endocardium, only 1 millimeter of this inner 1 millimeter, 0.1 millimeter of endocardium, they don't need any blood supply from coronary artery. They can get their oxygen, this innermost part of the endocardium, they can get their nutrients and oxygen directly from the blood that is present within the cavity. But other tissues of the wall, no. They can't use this blood directly. So what to do? How these cells will survive? They will be needing oxygen, they will be needing nutrients, because these cells, during the onset of our life, it has started its activity, and it will restlessly, this will be relaxing, contracting up to the end of our life. No rest, no pause even for a minute. So it is continuously doing, it has no fatigue. Like other muscles, we learn why cardiac muscle cells doesn't get fatigued. So how these muscle cells will get their nutrition, get their oxygen, wash out their carbon dioxide? So we have said, okay, don't worry. You are VIP. For you, we made some special arrangement. Through this special arrangement, you will be getting all your necessary things. What are these? For you, we made another special circulatory system. This is called coronary circulation. And this coronary circulation is very important, because within the path of these coronary arteries, if any blockage is there, the heart may undergo ischemic disease, undergo infarction, undergo heart attack. So for that purpose, we must learn about in detail, very deeply, properly, the anatomical structure of this coronary circulation, how these are supplied, they are supplying the ventricles, auricles, what are the different branches. Sometimes you will find in angiogram report, blockage is there in this area. Media means in this vessel of coronary circulation, LAD. In LAD. So what is LAD? You have to know it's a branch of coronary artery. Two coronary arteries we are having, left coronary artery, right coronary artery. From where they have originated, how while passing through, how they give out branches to different parts of the heart. And they are end arteries. What do you mean by end arteries? We will learn this. It will be a separate class, interesting one. So the inner, so what are the different layers we got? And this is the what is this lining? Inner lining, endocardium. Only a part of this endocardium may get its nutrients, oxygen directly from the blood that is present within the cavity. But other parts, no, they cannot use this. For them, they need separate circulation. And this epicardium is very prone, this question comes. Why this area, epicardium, is more prone to develop coronary heart disease? Why they are more prone? They have got very beautiful understanding. If anything is disturbing the circulation, other thing will come into rescue to counteract it. So with that they can auto-regulate. In case of scarcity, in case of emergency, they will try to auto-regulate it. We will learn this auto-regulation. So, again I am repeating, epicardium and inner endocardium. Very good. And this outer epicardium is made up of serous tissue. Okay. And myocardium is made up of cardiac muscles. These are thick. Most of the heart weight belongs to this layer, and the inner surface is lined by endocardium. Fine. Same thing. Layers of the heart, 3 layers. Epicardium, myocardium middle layer, endocardium inner layer. Epicardium is made up of mesothelium. Outside the muscular cord, there is what? Epicardium. It is made up of what type of cell? Mesothelium and connective tissue. Okay? It also contains blood vessels, lymphatics, and the vessels means they supply the myocardium, means blood vessels. Branches of coronary arteries. The myocardium. The middle layer is myocardium. It is the thickest part. This layer is composed of involuntary cardiac muscles. It forms bulk of the ventricles. These muscles are primarily responsible for pumping action of the heart. The cardiac muscles cannot afford to rest. They are restless, even for a single second. So it is absolutely essential that these muscles get blood supply and nutrition continuously, and it is done by coronary circulation. We will learn in detail. The coronary arteries supply blood and oxygen to the cardiac muscles. And next, thickness of the wall. What will be the thickness of the wall of there are 4 chambers. The top 2 chambers are atria, and bottom 2 chambers ventricle. And you will find the thickness varies. Why this thickness varies? It varies depending on, how much force you have to develop. You have to send blood from here to here, very close to this. So your length of the tube is short. So resistance will be very less. Frictional resistance The blood vessel, while blood flowing through it, it will undergo friction with the wall. Since the length is short, the friction will be less, resistance will be less. So this will be a low resistance path. Since resistance is less, so no need of what? High amount of force to develop. Only minimum force will be enough to pump the blood from ventricle into the lung through the pulmonary arteries. So this is the low resistance path. So since the resistance is less, distance is less, the amount of force generated by the ventricles supplying the lung will be less. So their wall thickness will be less. As a result, see, ventricle has to pump out upper two part auricles. So atria. What is the term I used? Auricles. Raise your hands. Auricles and atria both are same or different? If it is same, raise your hands. What was my question? Atria and auricle, is it synonymous or different? Who said it is different? Can you tell me why it is different? Oh, you don't know, but you know it is different. Okay, I'll make it clear. Yes, these are different. Auricles are not atria. The auricles are actually extension of the atria, extension of the outgrowth of the atria. Student सामने हमें काम नहीं my extension like ears. The meaning of the auricle is ear. Meaning of the auricle is ear. Latin word. This is the Latin word meaning ears. So ear-like projections come out from the auricle, from the atria. Two such auricles are there. From right one, from left one. So these are not actually atria. They are extension. Then what is the use of it? Are there any function of it? Yes. Retention function. When needed, it can retain some amount of blood. And the blood, if it is retained there for long, this blood can undergo clotting. When blood remains in a static condition, it forms clot. So these auricles may create problem if the blood is retained there for long. So keep it in mind. Anyway, so since the auricles has to pump the top two cavities, they have to pump blood into the ventricle, very short distance. And interestingly, 70% of the blood of auricles comes to the ventricle passively, without any contraction of the auricle. So what is अरे भाई तो ऐसे ही जाता है, वो जब ओपन हो जाता है ना, तो automatically it enters within the ventricle, and the remaining 30% comes through contraction of the auricles. So that's why it needs very less force to generate. So accordingly, its thickness will be less. How much? 2 millimeter. Its thickness is. Now my question to you. I have already explained. Now it is my option to that guy from Himachal Pradesh. Yes. Why the thickness of auricle is least? Questions can come? No? Can anybody answer properly? Yes? No? Yes? Coming passively. So no need of contraction. Only 30%. For this, it needs very minimum force to generate. Okay, so need unnecessarily thickening, unnecessary thickening of the atrium is not needed. That's why its thickness is less. Okay, good. Next, let us come to the ventricles. Let us come to the ventricles. Left and right. Left ventricle is thicker and right ventricle is relatively thinner. To pump the, listen, to pump the blood of right ventricle, it will be sending blood, pumping of the right ventricle, it will be sending blood to the lung. Very short distance. From here to here, from here to here, very short distance. Very less resistance. Left ventricle, right ventricle, pumping blood to the lung. Particularly the right ventricle pumping blood to the lung, very short distance. And short distance means low resistance. I have to send blood from here to the last end. Here to the last end. Suppose there is a pipe, so I will be sending blood from here to there, last one. And another case is there, I have to send blood from here to here. Now where I have to create more force, here or here? There. Why? Because the tube is long. While blood will be going, it will face lot of resistance. To overcome this resistance, moreover there are lot of blood will be there within the vessel. So I have to send the blood of the ventricles by overcoming the resistance and pushing the already existing blood in the vessel. So it has to create a lot of force. That's why its wall thickness is more. But in case of right ventricle, it is sending blood from here to there. Low resistance. Only it has to generate 25 millimeter of mercury. Whereas the left ventricle has to develop a pressure of at least 120 millimeter of mercury. 25 and 125. That too under resting condition. So definitely more force is generated in the left ventricle, so its wall is thickened. What do you do in the gym? You do it. And if you do it regularly, your muscles will be hypertrophied. Okay? Similarly, the heart, left heart is working against force, so its muscles become hypertrophied. This is as simple as that. Okay? Fine. What is the thickness of the left ventricular wall? While you will be doing echocardiography, and if you find the thickness of the wall of the ventricle is beyond 12 millimeter, then you will tell, oh, this patient is suffering from ventricular hypertrophy. And ventricular wall thickness becoming thin. Cardiomyopathy. Big heart. काम का नहीं है. It cannot create force. Blood बाहर जाता नहीं ठीक से. Most of the blood is retained within the heart. Big heart are not always good. Okay. Left ventricle, this is the interventricular septum, and this is the right ventricle. And this is pericardial cavity. This is the superior view. You are looking at the heart from the top. These can be visible. What are these? Great vessels. Aorta. And this sending blood to the one lung, and this part is sending, this branch is sending to other lung for oxygenation. These are deoxygenated blood, so there it will be oxygenated, carbon dioxide will be eliminated. Now it will be in your term it is now pure blood. Blood, pure, impure, no. Blood will tell deoxygenated or oxygenated. Okay, so there it will be oxygenated and they will be coming back from this, from one side through this, it will be entering, from other lung, it will be entering to this. And both of these will send their blood into this ventricle. See, and this is the anterior view. You are looking at from the front. So what you will find, what is this? Ventricle? Whose ventricle it is? This ventricle. Yes, it is so it is the right ventricle. So over it you will find the right atrium. This is the right atrium. And you will find a groove here. You will find a groove. This groove is extending, originating from the base of the pulmonary artery. So from this groove, it is going, okay, and coming back. So this is called what? Coronary sulcus. So this is the coronary sulcus. This group is called coronary sulcus. So this coronary sulcus has anterior view, anterior part. It is also having posterior part. Very important when we will be studying coronary circulation. So this is, what is this coronary sulcus? In between. Actually, the atrium and ventricle, the muscles of atrium has no direct contact with the ventricles. They are separated. They are separate. They work independently. No impulse from ventricle of myocardium cannot be sent. From here cannot come directly. Any impulse cannot come from here directly. Because in between there is a fibrous layer. There is a fibrous layer, and they are not capable of transmitting nerve impulse produced here and transmit it to there. There is only one way, only one path, narrow path is there through which the cardiac impulse generated in SA node can come to the AV node. And that is bundle of His. That is the only connecting electrical connection that exists between the both atrium and ventricles. And one of the important thing is this chamber, right atrium, at the posterior side, this side, at the, this is what? Superior vena cava. Inferior vena cava. So at the level of the inferior vena cava, in the posterior wall of the atrium, there lies a node. This is called as a node. And it is the pacemaker of the heart. We learn into this in our next class. So, these SA nodes are generator of the heart. They produce cardiac impulse. We know our heart has some important properties. One of the important property is automaticity. Means heart can generate its own impulse. And this generation of this impulse is rhythmical. As a result of this, our heart beats according to the rate at which SA node is generating cardiac impulse. If it produces 70 impulses in 1 minute, our heart will also beat in that rhythm. And the rhythm will be same. So it is the SA node for which heart exhibits automaticity and rhythmicity. Heart muscle is having another interesting property, that is excitability. We know only nerve cells has excitability and the muscle cells can be. If we put stimulus, they can respond by contracting. And they have got the contractility. So once impulse is produced, if it is conducted, another property is conductivity. We learned this conductivity. How many properties you came to know? Just name. One is automaticity and rhythmicity. Another is excitability. Another is contractility. Another is conductivity. The light is glowing. What will happen if I cut the line? No impulse, no current will be coming. Similarly, manlo, these walls are the wall of my heart. Through this wall, some electrical line is passing. And from this electric line, different points are given to the muscles. When this wall has to contract, the impulse has to go to all the muscles. Then only they will contract. If you cut this, they will not be contracted. Because ventricular muscles don't have automaticity. It cannot produce its own impulse. But there are some special cells, modified cardiac cells, special cells, they can only produce this. One is SA node, another is AV node, another is bundle of His. They can produce cardiac impulse. But SA nodal impulses, they produce at a higher rate. But the others can produce at a lower rate. So when SA node acts, the other two remain, will not say anything. We will obey your order according to your impulse, total heart will be. When in your absence, then we will be coming into action. AB node will come in action. If AB node is also destroyed by some means, then Purkinje fiber, but chances of living is very poor. So, Purkinje fiber can generate only less than 20. AB node can produce 40. Whereas our SA node can produce 60 to 80. But SA node can produce, if necessary, more than 200. About 200. If I give you a strenuous exercise, can you predict, can you tell me how much, what can be maximum, what can be your heart rate? Simple. It is very simple. 220 minus your age. 220, and what is your age? You are 15. So minus 20 minus 15 or 25? 20. Okay. So 220 minus 20, 20. Result is 20. So if I give her strenuous exercise, her heartbeat may go up to 20. He is 17. No, 16. 16. 17. So 220 minus 17, 203. So 203, his heart rate may go up to 203. So this is the target heart rate. The rest part will be on different chambers. And today which group are having practical? So this part I will finish in the practical. So what was endocardium? It was the innermost layer. Confused Krishna. Pericardium gone. Pericardium is outside. It is most inner lining. Okay. And this layer endocardium up to 0.1 mm thickness, the part, these are mainly epithelial tissue, they don't require any separate circulation from the coronary arteries. Why? They can directly take oxygen, nutrient from the chamber. So a lot of blood is there. They can take their nutrients, oxygen. But these tissues cannot draw their necessary items from there. For that, they need separate circulation. Now see, in the endocardium, what we saw, what is there? First, after the muscle layer, there is a thin connective tissue layer. Then only mesothelium means what is this tissue? Most simple tissue? Epithelium. So the epithelial lining. Okay. Now you take connective tissue and the epithelial lining. Take a strip. Okay. Then you do one thing, fold it. So what will be there outside? What will be there in this? I have taken a piece. Within this, what is there? The inner means over the epithelial layer, there is connective tissue layer, and outside is the epithelial layer. Now I folded it like this. Now connective tissue came within this. Now you can make with this a valve. So what the actually valves are made up of what? They are made up of, in the valves, valve leaflets, cusps, they are actually made up of with what? 3 layers. Within outer and inner, this folding. So, suppose this is the valve. So this layer and this layer is the epithelial tissue, and within, like sandwich, within what it is there? Connective tissue. So with this sort of material, all the valves are made. Clear it is? Because the valves have to be, connective tissue is there, it has to be strong. And the sides should be smooth. So that's why epithelial tissues are there. So epithelial tissue, top surface, bottom surface, and in between connective tissue. You got the idea? Clear? Okay. All the valves are actually made like this. Each heart valve is formed by a fold of endocardium with connective tissue between the 2 layers. Is that clear now? Okay. This is the anterior surface you are looking at. So this is my anterior side. So you are looking at the heart from the anterior surface. And if you move it like this, you will see this. Now you can see one thing. There is a groove. There is a groove. This groove went back. One branch came down. It is the back side. Look, okay, let's see the back side. So that this groove is actually this groove. What is this groove called? Good. Today you learned. From anatomy class, hopefully. Today there was dissection of heart, no? Okay. So, you have seen this coronary sulcus. Okay? Another thing, from the anterior view, this sulcus divides this part and this part. The sulcus, these are made up of fibrous tissue. Made up of fibrous tissue. And this fibrous tissue actually separating atrium and ventricle. Separating, these are the atrium and this is the ventricle. So these are separating these two. So you will not find any functional connectivity between the two. Here, the muscles, cardiac muscles, they are not connected with these muscles. Separation. What about activity will be there that will be retained within this, that will not be transferred to this. Very important. Why? When auricle will be contracting, ventricle will not be contracting. When the contraction of the auricle is finished, then only contraction of the ventricle will start. Now tell me one thing, why this? Why not simultaneously? What is the problem? In case both are contracted simultaneously? Backflow. When auricle contracting to send its blood to ventricle. If ventricle is at the same time is contracting, can this auricular blood enter within the ventricle? No space, because it is contracting, it is sending its blood to somewhere else. So auricular blood cannot enter within this. So if I take some time, if I say ventricle, you wait. Let me finish my job. Let me contract, send all my blood to you. Then only you contract. then you will be able to send your blood to the circulation. So what to be done? Because SA node is producing a signal. And this signal is spreading continuously, immediately throughout the atrium. And this impulse, if it comes immediately to the ventricle, then ventricle will also be starting contracting. Same thing, problem is starting. So, one thing can be done. If I make some delay here, you come, okay, no problem. But I will send it later. I will send it very slowly. This is actually done. Impulse is coming. Impulse is spreading from SA node to the all atrium. First, SA node, where it resides? It resides in which auricle? Right atrium. Good. It resides in, it is located in right atrium. So, from here, impulse started spreading. So, first it will cover the right atrium, then it will be going to the left atrium. Okay. So, in electrocardiography, if you find one of the auricle is enlarged, one is small, and you can identify this by seeing the P waves. It will be reflected in P wave. It will be a tent-shaped P wave. Otherwise, it will be normal shape. No need of writing now. It is not. It is when we will be discussing doing electrocardiography. Then it is important. There I will discuss. So, under normal condition, though right atrium gets first impulse from SA node, left atrium gets later, but it is fast. So, you will not get time gap is very minimum. You can say it is simultaneous. Now, while spreading this impulse ultimately try to enter into the ventricle, but it will not. Because for entering there is only one gate, and that is AV node. Only through this gate the electrical impulse of atrium can travel to the ventricle. Then only ventricle depolarize first. The action, these are impulses what? Cardiac impulse means action potential. This action potential will be spreaded over the ventricle. Then the muscles will contract. Okay? So that's why you can now see the importance of these coronary sulcus. They are preventing, separating myocardium of atrium from myocardium of ventricle. Otherwise, problem is So, these fibrous cord, they are not a good conductor. They are very bad conductor. So, if it tries even, the sulcus, the fibrous tissue will not allow. Only one way is there, that is the AV node. We'll discuss in detail. That will be a separate class. Very important. For example, I am diverting. Heart block. What is heart block? What is your idea?
आर्टरी जो डिस्ट्रैक्टेड ब्लॉक हो जाए जो ब्लॉक हो जाता है सर डिपोजिशन
अच्छा आर्टरी ब्लॉक हो जाता है और एनीथिंग एनीबॉडी एल्स This room is having electrical wiring. Our heart is also having electrical wiring. These wires collecting impulses, current from the SA node. With this impulse is spreaded to the ventricular muscles. Through different lines these are coming. Through different tracts these are coming. If one of the tract, for example, concentration must be here. SA node, they are producing nerve impulse, cardiac impulse, not continuously, rhythmically. One impulse, another impulse, another impulse, another impulse. This way it's going on. Suddenly you became excited, then your heart is also excited. So, impulse, 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 faster. When you started running, you need more oxygen, more blood to the tissues. Then, SA node again, more faster, impulse, 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 200 times. So your heart will also be beating at that speed. That's why similar activity, as I said in the class, our heart, muscles, heart is having some important characteristics, properties. What are these? One is important one is automaticity. If you cut my heart, isolate my heart from my body and keep it here, you will find my heart is beating. Though it is separated from the nerves. How it happened? Because of the automaticity. And where this automaticity lies, not in all cells, in SA node. Since it is, that's why it is called pacemaker cell. This area is made up of P cells or pacemaker cell, P cells, pacemaker cells. These are actually special kind of cardiac muscles. They modified themselves particularly for performing this function. Their function is not to contract, not to relax. Only thing, produce nerve impulse and conduct it. Conductivity. Another property of the cardiac muscle. So, it will conduct these special cells. They can conduct the impulse produced in the SA node or pacemaker throughout the cardiac muscle. So, this is conductivity. And when this will be going to the cells, this impulse, the cells will be respond because they are excitable. How they will be responding? By contracting. So we can say they are having automaticity and rhythmicity. Automatically I can generate. But impulse, then stop. Again impulse, no rhythm. Tick, 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 no rhythm. If it happens also. Then we call it arrhythmia, irregular heart beating. And it is the malfunctioning of the SA node. If it functions abnormally, then only we need pacemaker, external pacemaker, artificial pacemaker to suppress the activity of the original SA node. Now SA node is the temporary pacemaker or the artificial pacemaker. It will produce rhythmic impulse and this will be transmitted. So, I will be surviving. Otherwise, what will happen? Here is the SA node. Here is the B node. And there is no connection in between. Because this connection is lost. Now this SNOID is producing impulse. And it is not getting any impulse from here. So it will start, Amar Dada done. So now I have to show my activity. So it started its activity. It also started. There is some irregularity. This is called AV dissociation. Through electrocardiography, you will find AV dissociation. Irregular heartbeat. One rhythm is produced by this, another rhythm is produced by, there is haphazard condition. We learn this. AV dissociation. Okay? So it can be corrected if I put one pacemaker. Now, their activity will be suppressed and its activity will be the final. With its, according to its activity, the rhythmicity of the heart, contractility of the heart will be maintained. Okay? So now, we have seen these, how these are important. Another thing you see, another groove is there. In between the two ventricles, separating the two ventricles, left and right. So, what is the name of this? Anterior? Interventricular. Same thing is there at the back. We'll see some coronary arteries, branches of coronary arteries. We can see with this sulcus, we can see up to this part is right ventricle, and the left ventricle, from the anterior view, part of the left ventricle you can see. Most part is at the back. Okay? We have seen how electrocardiography is done. Maybe you have seen. Some electrodes are placed here, there. Okay? One here or here it will do. So why you are placing like this? What is the need of that? There was an island. In that island, there was no hathi, elephant. There was no elephant. The people of that island, they never seen how it looks, what hathi is, elephant is. So government of India, okay, I will send one hathi, one elephant to that island. So what they did? The transporters, they made a box. Within the box, the hathi was kept, and there was at the front there was a hole. At the side also there was a hole, and at the back there was a hole. Otherwise, everything is covered. The hathi has to breathe, no? That's why a hole is needed. Then what happened? The hathi was shifted in the cage, in the box, shifted to the island. The people, some people, they were so curious to see the elephant, say went to the shore. When it was put on land, within the box, people started seeing the elephant. Somebody got the scope to see the elephant through the side. Somebody got the scope, seeing the elephant from the front, and somebody see it from the back. So there are suras, somebody, they could get only one scope. Only one, they could not see the others. So they left. The people in their community, they are asking, hello, how, what you have seen, how the hathi looks. The person who saw the hathi from front, he described hathi like this. Hathi is an elephant. Hathi is like, it is having this and this and that. And who saw the hathi from the back, you don't know, hathi looks like this. And who saw from the side, he said, you both of you are wrong, hathi looks like this. So what is the interpretation? Unless you see the whole thing from different angles, you cannot describe one thing in detail. If you want to see my heart, you have to see my heart from the anteriorly, laterally, and posteriorly. Who knows? Some muscles of ventricle of anterior side is not affected. Only at the posterior side is affected. Then this abnormality can be detected by that one only. That's why we have to see the electrical activity of the heart from different angles. Side view, anterior view, and all. Okay? Now coming to the original aspects. One thing it is became clear to us, both atrium and ventricle work independently. Okay? Means we can say here there are two pumps. Auricle is one pump, ventricle is one pump. Both the ventricles will contract simultaneously, both will relax simultaneously. Both the auricles also will contract simultaneously, will relax simultaneously. Not that auricle, ventricle, both of them, all the four are contracted simultaneously. It doesn't happen. Why it doesn't happen? Because of this fibrous sulcus and the junctional tissue, AV node. The AV node is such that its cells are, we know, we have seen the nerve fibers, those who are having higher diameter, long, they can transmit signal fast. Those who are having small diameter, they can transmit signal slowly. In AV nodal, after AV node, what is there? Bundle of His. In bundle of His, just initial part, the cells are, the conductive tissue cells are such that they are very thin, insulated, and so through that passage of nerve impulses is very slow. Actually, it is giving the atrium, okay, finish your job. If it is finished, then only I will, because next part of the road is, means next part of the cells are having higher diameter, longer in size. So once it will be reaching there, it will be spreading fast, very fast into the all ventricular muscles, so that all the ventricles can contract simultaneously. You understood this point? So make it clear. Now tell me, what is this? Very good. Arch. I said, what is there at the back of my heart? One of the component is descending aorta. Descending aorta. Okay? And what are these? See, this is aorta, but its chamber is not here. This aorta is getting blood from left ventricle. But where it is? It is not this. It is there, at the back side. So from there actually this is coming and spreading. And this one is sending blood, right ventricle, sending blood to this. Going to the lungs. One branch will supply the lungs, another left lung, another to right lung. Okay, so and this is the pulmonary vein. Then from now what you will tell? What are arteries? Will you forget this thing? Never? Okay. Abhi bolo, what is vein? That brings blood to the heart. Very nice. Now, chambers of the heart. How many chambers we have? 4. अच्छा, मुझे एक क्वेश्चन है. Atria versus auricle. Both are same? Different. Oh, already I said in the class. Extension of ear like extension of auricle. They are not considered as auricle atria. And their function is they can store, they can keep some blood if necessary. When it is over distended, so some blood they can accommodate if necessary. And if this blood, as I said, remains stagnant in the blood, then it may form clot. And if this clots can come out of the auricle, then this may, while it will be flowing, if it by any chance it enters within the coronary arteries, then going to die, because they will block the arteries. The lumen will be blocked. It may happen in anywhere. What is this condition? When excess, too much of fluid is retained in the pericardial cavity. Too much. I said too much, not excess. Too much is more than excess. Tamponade. Remember, that's why again I am saying, remember this thing. You will be confronting these words, these terms. Tamponade. In some echocardiography you will find tamponade is there. Effusion is there. Pericardial effusion is there. So these are abnormal. See the ER of the atria means auricles. Have you seen auricles in your dissection class? Okay. Chambers, 4 chambers. Upper 2 chambers, we said, yeah. This is the group, sulcus, separating these from these. No continuity, myocardial continuity. Every chamber, something is circulating, blood is circulating. So they must be having inlet, outlet. Inlet, outlet. For atrium, in inlet there is no valve. But for its outlet, there are valves. These valves are in between atria and ventricle. That's why we call them atrioventricular valve. We'll study their structure. Remember this. Atrium to ventricle. Atrioventricular. So two atrium is there, two ventricle is there, two AV valves is there. One AV valve is having two cusps. Two cusps. There is one ring at the orifice. Orifice means opening in between atria and ventricle. So covering this opening, there is a ring, fibrous tissue ring. Now the valves remain attached to the ring. These are fixed, these ends are fixed. So this end is fixed to the ring. But other ends, like tongue, smooth margin. The margin is smooth. And it is such that, we'll show this picture, it is such that atrium, ventricle. So blood will flow from here to here. So definitely valves will not be like this. This will be like this. So this is the ring. So within this ring, the valve flaps, cusp remain attached, and these are the free ends. And at the margin of these, along the margin of these, and from the bottom of these leaflets, cusp, there are some thread-like structures. These are called cordae tendini. And these cordae tendini are actually originating from ventricular wall through a ridge. This ridge is producing these threads, and these threads are joined to the periphery of the cusps and at the center. Outer surface is smooth. Outer surface is smooth. Now you see what happens. These are like this. This is the atrium. If it remain like this, now this is the ventricle. Valves are closed. Valves are closed. Now the ventricle started distending. What will happen? Inside, pressure will fall, and it will be, when it will be less than the atrium, blood in atrium, within the atrium blood is there already coming through SBC and IBC. So it is full. It is full but cannot enter. Why? It is closed and ventricle is squeezed. Now ventricle started expanding. So there will be a negative pressure. Pressure will be less than the blood. The pressure, the blood having in the atrium. So because of pressure difference, sudden pressure difference, the blood will start entering into the ventricle and they will go away. Because of the pressure, downward pressure, the valves will go away. Now you think, that means passively blood has had and passively blood is entering because of expansion of the, no contraction of atrium. Because of expansion of the ventricle, there is negative pressure. Volume has increased but no blood. So as a result, what will happen? From the atrium, blood will enter. Opening the valves will be opened. They will be separated. And by this time, what happened? After some time, 70% blood entered passively. Now what will happen? Atrium will contract. Contraction time of atrium is much less, 0.1 second. Whereas for ventricle it is 0.3 seconds. So for 0.1 second it will contract. The rest of the blood will be entering within this. Okay? Now the ventricle is full. Now it is the turn of ventricle to contract. What will happen? There will be pressure within the blood. So they will try to close the opening. Okay. If it is too much of pressure, the flaps, they may open reversely. So blood from here, without going to normal direction, it will again will enter into the atrium. So how this can be prevented? By the chordae tendini, they will not allow to bulge. They will not allow to bulge because when the ventricle will be contracting, papillary muscle will also be contracting. If papillary muscle contracts, they will pull the valves so that it is not bulged. Let's see one thing. Here it is. Chordae tendini. Better picture you'll get. Have a look. Chordae tendini, papillary muscle. Okay? So blood is entering. When it will be contracting, the pressure, here pressure will rise. So they will try to enter again into the atria. So because of pressure, this flap will be closing. And the surface is smooth and they will be opposing to each other. There will be, so though no gap will be there. And if it is bulged out, then what will there? Opening will be created, blood may come out. To prevent that, they will pull. They will prevent bulging. It will be, this will not contract, only they will contract. This contraction will pull this chordae tendini and they will prevent bulging of the thing. It may happen. Bulging may happen. Why? It happens. Tearing of chordae tendini. What will happen? So when your ventricle contracts, some blood will be entering into atrium, and this is called regurgitation, and it will produce murmur. It will produce murmur, so you can identify there is something wrong. Okay? Or these muscles, they can be paralyzed. If they are paralyzed, it happens. A lot of cardiac patient will get the echocardiographer. He will identify these muscles are not working. It can be easily. If you see, you will be, by saying it, you can also say it is paralyzed. It is not contracting, relaxing. Simple. So what will happen? There will be bulging because these muscles are not working. So these are another point of abnormality you can find there. And another thing you can see, the inner surface of the ventricle. What is this? These are the trabeculae carni. When heart will be dissected, opened, you will find it. You will see this. Okay? Fine. Separating both the atrium, there is one septum. What is this called? IAS. In echocardiography report, IAS intact. In some infants, what happened? They are very weak, they cannot run, they become easily tired because there is a perforation. There is actually, when infant or at the intrauterine stage, there is a hole. It remains a hole. What is this hole called? This hole is there, but after birth, it's healed up. It is closed. If it is not healed up, then what will happen? Both blood of both atrium will be mixed, and deoxygenated, oxygenated blood will be mixed, and there will be the lung will get more blood, oxygenated and deoxygenated both. Okay, so it may damage the lung. So in that case, surgery is there. By surgery, how the joint is made? What used? Soldering machine. Huh? This sort of soldering machine is there. With that you can repair it. It's like that only. Okay? Fine. So there are various kind of this sort of 3-4 types of diseases of the septum, IAS. The most common is commonly seen in infants. That is repairable, correctable. Okay. And there is another septum in between the ventricles. That is IBS. That is IBS. Normally IBS is straight. But in some diseases it may bend like this. When there is any hypertrophy, it may no need of writing. So it's just for your knowledge. These are also a point of disorder. Okay. Now, the valves, as I said, every chamber has inlet, outlet. For atrium, there are inlet, no valves. But for its outlet, there are valves. And these valves are what kind of valves? Bicuspid or tricuspid. They will be having chordae tendineae, and attached to it, what will be there? Purkinje, not Purkinje, papillary muscles. Understood? But in case of other valves, semi-lunar, it is not there. I'll discuss coming to this. 4. So, one valve is tricuspid. 3 cusps are there. And one is bicuspid. Now, who can tell in which AV valve is bicuspid? Left ventricle. Can you everybody remember this? You have to remember this. Okay? So it is the And it has got another name. It is also called mitral valve. Bicuspid. Bicuspid valve or mitral valve. Okay. In reports, you will find mitral valve. They will not write anything heavy valve. They will write mitral valve. So immediately you have to know, this is this valve. Lot of problem is there in mitral valve. One lead is longer, another is shorter. As a result, they cannot close properly. Inappropriate closing. So there will be regurgitation. You will hear hard murmur. There may be sclerosis. What is sclerosis? Sclerosis means when the opening becomes narrowed. And this narrowing may be result from deposition of calcium ion. The patients who are having rheumatoid arthritis, they have a chance to develop this sclerosis. Sclerosis in the mitral valve. Sclerosis in the aortic valve. Sclerosis in the pulmonary or tricuspid valve. It can happen anywhere. Sclerosis can be done anywhere, can be made anywhere. And whenever there is sclerosis, so there will be improper closing or opening. So there will be regurgitation of that. So a lot of problem. Acha. Apex of the heart. Cone shaped, the apex of the heart. Is it the part of apex of the heart? Is it the part of right ventricle or left ventricle? Good. Base of the heart? Left atria. So good. Very good. You learned it very well. See the section. Thickness of left ventricle and thickness of the right ventricle. The contraction of this ventricle can generate only 25 millimeter of mercury pressure. And it can generate normally 120 millimeter of mercury pressure if necessary. Today morning, before coming to class, at least half an hour, I started not feeling well. Immediately I checked my blood pressure. It was 202 by 107. I thought, how can I go to college? Anything can happen on the way.
No, sir. Don't say like this, sir.
Then I took some rest, took one anxiolytic, one hypotensive drug. Within half an hour, my driver, he went there. I told him, you wait for some time. So after again I checked, it came down to 96 diastolic pressure. No, it will be coming, and now I am feeling well. Whenever any change, pressure change will be there, you will identify, you will be now knowing the signs, symptoms. You have to remember, when any patient says, I am feeling like this, so you have to assess the patient is having hypertension or hypotension. So you have to learn this very well. Okay, the early sign of what is angina? What is angina?
Pain.
If he sits on your leg, on your thigh, After some time, what you will feel?
Pain.
Numbness of your leg. This is because of angina. This sensation is angina. Angina of these muscles. Because when supply of oxygen is reduced, then this sort of sensation develops. It may happen in heart. You will feel pain, heaviness on the chest. And it may radiate. So these are the signs. These are the signs of ischemic heart disease. And myocardial infarction. In that case, what happened? Not only minimized, totally blocked. As a result, some part is totally became devoid of supply of oxygen. Some part of your ventricle, maybe atrium, devoid of oxygen, nutrients. And this tissue, if it remains like that, the tissue will die. The tissue will be rotten in 72 hours. But other part is okay. So when other part will be contracting, they will be ballooning and there will be rupture. All the blood will be drained out. That's why 72 hours is given. Why 72? Because collaterals, the area which is devoid of blood supply, this area may get collaterals from surrounding vessels. This is the advantage of the coronary circulation. It will try. It's level waste. That's why after first attack, second attack, when the attack area is much bigger, then there is no chance. Okay. See, from the top, you cut the vessel part. From the top part, you are seeing from the superior part, seeing, if you cut it, you will find this. What is this? Bigacil. Means the blood, this is what? Atrium. Huh? Left atrium. So from its, when its blood, when it will be relaxing, then automatically this will open. Blood will enter. When the ventricle will contract, this will close and it will open, go through this. This is what? Aorta. See how many cusps are there? They're nice. Your finger up to this, it can penetrate in this sinus. One finger. You try when it will be open, whether it goes up to this. So there are three. How they work? They don't have choroid tendini. They don't have. Then how it works? When from the ventricle blood is ejected, these cups open up. Comes to the side of the aorta. Ejected. So now ventricle has started relaxing. The aortic blood will start to come back. Will start to come back and it will create a sound. Sudden closure of these valves. These are first heart sound or second heart sound. This is the second heart sound. See, first, this is very easy to remember. Are Babu, see. Hold it. Ventricle. So, it is dilating. It is dilating. When this is started dilating, before it was contracting, so at that time, this aortic valve was open. Now it is relaxing. Here the pressure is Now so blood from aorta will try to enter. So they will push from backward, push these valves, semilunar valves. So because of this pushing, all the cup will come to the center and close. And this will make a sound. A sound that we hear, actually it is a sound of what? When it is suddenly closed, it creates vibration among the surrounding blood. This vibration is the sound, creates the sound. The sound is the second heart sound. The first what happens? First one will be closure of the epivalves. Closure of the, remember, there are two closure epivalves. Bicuspid. What happens? Ventricle is expanding. So they opening doesn't produce any sound. So they will enter. From right atrium, blood will enter. Now ventricle will start. First, which valve is to be closed? Epivalves. Otherwise, the blood will go to the atrium again. So they will create the first heart sound. Okay. So when ventricles start contracting, immediately the first, which valves are to close? Otherwise, blood will enter into the atrium. So first they close it. It will create the first heart sound. Both the tricuspid and bicuspid, they will simultaneously will close and they will simultaneously produce the same heart sound. Is that clear? Not clear to that girl. Okay, I'm sure, 100% sure. Secondly, second heart sound. When we will hear? It is contracted, so contraction is closed. Now, aortic blood will open, semilunar blood will open, go. Aram say no heart sound. But when it will be relaxing, then blood will try to come back within the ventricle, and this closure of semilunar valves will create another sound. There are two semilunar valves. Both will be closing simultaneously. They will create the second heart sound. There are two other sounds. Fourth heart sound and third heart sound and fourth heart sound. When third is hard, you cannot hear it by stethoscope. You cannot hear it by stethoscope. But what sort of sound it is made, why this is made? When ventricle relax, the auricle will not contract. The blood within the auricle will pass passively. The blood will open. It will open passively very fast. And this sudden entry of atrial blood into the ventricle, that will create a sound vibration along the wall of the ventricle, interventricular septum, and this is the fourth heart sound. And again, when the atrium will contract, again 30% blood will enter. That will create the fourth heart sound. Is that clear to you? When we will see, you will hear the first heart sound, second heart sound, third, and fourth. You study. Two books will do. The books of this fellow, Jain and G.K. Paul. Okay. Now you can see the flow, it is known to you now. Where is it? Superior vena cava, inferior vena cava, entering. Started relaxing, automatically it will enter. No need of contraction. 70% of the blood entered. Okay. Next it will, after that it will contract. Rest of the 30% will enter. The fourth heart sound initially, when 70% entering, very fast, one sound will be, that is the third heart sound. And when with this contraction, another sound you will hear, that is the fourth heart sound. Okay. So then they will contract. So this will be closed. Chordate tendon is there, this will be closed. Now blood will be entering. They will be going to both the lungs. Because this blood is deoxygenated. So oxygenation is needed, for that they are going to lung. Okay. And what will happen to this? They will enter into the aorta. It will spread throughout the body. Here the oxygen will be utilized. अच्छा एक बात बताओ सबके लिए, जो वेनस ब्लड है ना, वेनस ब्लड, उसमें क्या ऑक्सीजन नहीं है क्या नहीं? वेनस ब्लड में ऑक्सीजन है क्या नहीं? Then why are you calling it deoxygenated? No, इतना ज्यादा नहीं है.
ऑक्सीजन से ज़्यादा
Oxygenated blood. Take 100 ml of oxygenated blood. How much? Just take and check. You will get 19 ml of oxygen there. How much? 19 ml. Now take venous blood. Take venous blood and check how much oxygen is there. Hurry, 14 ml. 14 ml. Are you are telling deoxygenated? Still, it is having oxygen, but relatively less. But having relatively less. So from every 100 ml of blood, you are extracting how much oxygen?
5.
Difference is how much? 5 ml. From every ml, every 5 ml, every 100 ml, you are drawing
5 ml of oxygen.
See the case of heart. Heart muscle is every time working, its needs of oxygen is much, much, much high. If you take 100 ml of oxygen, arterial blood, 19 ml,
Oxygen.
I say, sir, I am taking a lot of time. No. I say, sir, you are telling 19 ml. Why 19 ml? Why not 25 ml? Why not 22 ml? Can you answer anybody? Why it is 19 like and 19, 20 in between? It's very simple. Now you'll understand. You don't want to correlate, now you correlate. You will find the answer. Shamir, what is your hemoglobin content per 100 ml? If you take 100 ml of your blood and you study hemoglobin content, how much hemoglobin you can have? 14? Huh? 70. Hey, normal values. Huh?
12 to 18.
मरेगा तुमको. यूनिट कौन बोलेगा? ग्राम 500 ml. Okay. Silent. How much? Take it 15. 15 gram. I know 1 gram of hemoglobin, every hemoglobin can carry 4 molecules of oxygen, 100% saturated. Now, 1 gram of hemoglobin in this condition, when 100% saturated, it can carry only 1.34 ml. 1 gram can carry 1.34. So you are having 15 gram. So how much you can carry? See the product, how much it comes?
Twenty.
20. Because why the value is not 19? Because you have your hemoglobin content you considered 15. If you make it 14, the value will be less. So that's why it is 19. That's why 19.5 or something. You cannot have 20 gram of hemoglobin. If you have, suppose I gave you certain, from external source I gave through injection, so for perfusion, I gave you a lot of RBCs. So your hemoglobin will be more. But what will be the consequence? What will happen to your blood? What will happen to your viscosity of the blood? It will increase too much. Your pressure will be increased. So everything may be disorganized. So everything has got a limit. Okay? So, but anyway, now you can see why it is 19. So, important point. When 100 ml of arterial blood is going to heart muscle, it will be having per 100 ml how much? 19 ml. And you take the venous blood. That coronary circulation will be also be having vein. So you collect 100 ml of blood. And if you analyze it, how much oxygen you will get? 5 ml. How much you have extracted? 19 minus 5.
14 minus 14.
13. More than 70 to 80% of the oxygen that is arterial blood is carrying, that will be extracted by the muscle. And these muscles are having myoglobin. Myoglobin has got more affinity for oxygen than hemoglobin. So it will take up, forcefully it will take up oxygen from the hemoglobin into the myoglobin for its future use, contractile use, every time it is needing. So that is one of the features of cardiac muscle. It can extract more oxygen. The power of extraction of oxygen is much more. So I am going to close. You know that. See, this is the closed curve. These are what type of valve it is? Semilunar. This is closed. Now what happens? ऐसे क्लोज हो गया. इसका पीछे क्या है? इधर if it is aortic valve, इसका पीछे इधर और इधर दो एपर्चर है पीछे. वहां से एओर्टा की वॉल से क्या निकलते हैं? कोरोनरी आर्टरी. Left coronary artery and right coronary. In our next class, not the coronary, we will do conductive, SA node, AB node, how SA node generates pacemaker potential mechanism. We will learn, and how these are transmitted. That we will learn. At the several point there may be blockage. Right bundle branch. In ECG, your report. Interpretation RBBB means right bundle branch block. LBBB block. So block. So these are blocks. If these blocks are not blockage of the arteries, these are different. That's why I told you, what do you mean by heart block? That is also block, but that we classify them in another way. We learn gradually. So you keep your interest on this. You try to learn this. If you have any doubt, those girls, she is having doubt, come and I will make it clear to them. Okay? The two types of circulation is there. One is systemic circulation. Can you tell anybody pathway of systemic circulation? Left ventricle to aorta to whole body, then coming back to right atrium. That is systemic circulation. Greater circulation. Here, resistance is more. Blood has to travel a long path. So this blood has to be driven with a great force, and this are to be created by the left ventricle. That's why it's thick. And the other one? This is systemic. Another is? What is the root?
Left atrium. Right ventricle to lungs.
Right ventricle to lungs. From there it is coming back to left atrium. That's all. Very short route. So no need of generation of so much of force. Path is very less. Very less. And the diameter is also big. So no resistance. Easily can go. Okay, only 25 millimeter mercury pressure will do. But there we need at least 120 millimeter of mercury pressure. So next day we'll explain this thing. Important. Very important. Then we'll study coronary circulation.